Hello everyone. In this session, I am going to discuss a very important disorder, that is Paroxysmal Nocturnal Hemoglobinuria. It is known as PNH. The full form is Paroxysmal Nocturnal Hemoglobinuria. So let's start it. So the topic is small yet very important, right? So I will be describing the topic under following headings. First, I will let you know the introduction, then pathogenesis, then clinical features. In the clinical features itself, I will tell you the typical triad of PNH, right? Sometimes you get a question separately on the typical triad of the PNH you can see, okay? So just a second. Okay, so you can get a question, the triad, coming on the lab diagnosis, the screening test and the confirmatory test. So let me start with PNH, Paroxysmal Nocturnal Hemoglobinuria, right? So what is Paroxysmal Nocturnal Hemoglobinuria? It is a type of hemolytic anemia. Basically, it is a type of acquired hemolytic anemia when there is a defect in the cell membrane of the RBC, leading to the hemolysis of the RBC. What is the cell defect? There is a gene known as GPI, that is glycosyl phosphatidyl inositol. Glycosyl phosphatidyl inositol present the gene in the RBC that is mutated, because of which the cell membrane become defective. I will explain. So for explaining, let me draw a diagram, right? A simple diagram, a sketch diagram, the lumen of the blood vessel. The lumen of the blood vessel contain RBC, it contain WBC, and it contains platelet also, right? I'm drawing the three type of cells, RBC, WBC, platelet. The three type of blood vessels are present in the lumen of the blood. Okay, so what is the problem in that? You know, we all have complement. What is complement? Complement system is present in the blood. C1 to C9, complement. There are 9 proteins present in the blood, but they all are inactive. They all are inactive. You know what activates them? Whenever the pH of the blood is acidic, they get activated. In acidic pH, they get activated. Now, this is basics, I guess everyone knows it. In acidic pH, the complement get activated. So, whenever we sleep during night, during sleep, the respiratory rate fall, our respiratory depression is there. It is physiological. So, because of which there is little bit metabolic acidosis whenever we sleep. So, normally person sleeps during night. You know, I don't know about you, but most of the persons sleep during night. So during night, when the person is sleeping, at that time there is respiratory depression, which is physiological, leading to acidic pH. So at that time the complement will get activated. So you will say, ma'am, what will happen if the complement get activated? On activating, the complement will cause the lysis of the blood cell. So RBC, WBC and platelet, they all should rupture whenever complement get activated. You say, ma'am, it doesn't happen. We sleep daily. Daily in the night I sleep, you sleep. I guess everyone sleeps during night, right? We all sleep, right? So if it is the case, in the morning we should have pancytopenia daily in the morning, but it is not the case. So why it is not the case then? Because God has provided us two guards on all the cells. The two guards are preventing us from the activated complement. The name of the two guards is CD55 and CD59. It is present in all cells, on RBCs also, on WBCs also, on platelet also. The two guards, CD55 and CD59 is present in all of them. These are guards. So during night, whenever the complement get activated in acidic pH and the complement is trying to do the lysis of the RBCs or WBC or platelet, the guards prevent the complement to do the lysis. That's why in the morning when we get up, we don't have pancytopenia, because thankfully guards are present in us. So CD55 is known as DAF, decay accelerating factor. That is the name of this guard. And CD59 is known as MIRL, that is membrane inhibitor of reactive lysis. The name indicated is the membrane inhibitor of reactive lysis by the complement. So decay accelerating factor and MIRL, these are the name of the two guards. CD55 and CD59 are present, right? So both of them are synthesized from a gene. The precursor is known as GPI, that is glycosyl phosphatidyl inositol. So we all have this gene which is synthesizing the two guards. From this gene, the two guards are synthesized, right? So we don't have the lysis of the blood cells during night. But imagine a person in which GPI is mutated. The GPI is mutated. So GPI precursor will not form. So CD55, CD59 are absent in them. So during the night, when such person go to sleep, during the night, due to the respiratory depression, which is physiological, whenever the pH falls, during night the pH falls automatically. Whenever we sleep, our pH in the blood falls automatically. It's metabolic acidosis, which is physiological. So complement will get activated. But these persons in which GPI is mutated, they don't have the guards. So the complement will cause the lysis of all three cells. So they have pancytopenia. right? They have pancytopenia, so rupture of RBC, WBC platelet takes place in the blood vessel only. So hemolysis is intravascular. It's intravascular hemolysis taking place. So in the blood vessel lumen only RBC is rupturing. Not only RBC, WBC platelet also rupture. So patient have pancytopenia, patient have hemolysis. You got my point? And that's why, so whenever the RBC rupture in the lumen only, the hemoglobin is released in the blood. This hemoglobin will go in the kidney and the urine. So patient have hemoglobinuria. So patient have first morning urine red in color, because the first morning urine, it is having hemoglobin in that. The hemoglobin in the urine coming from the hemoglobin in the blood. The hemoglobin in the blood is coming by the rupture of the RBC. You got it? That's why it is known as paroxysmal nocturnal hemoglobinuria. Now you can understand the three terms. What is paroxysmal? It is an attacks. It is not constant anemia. Every night patient have anemia, but the morning it's normal. Every night, whenever the person is sleeping, person have hemolysis. Whenever the person is wake up, the person don't have hemolysis. So it is not continuous. It's paroxysmal means it is attack. It is periodic. Nocturnal means it is during night, because person sleep during night. Normal person sleep during night. And hemoglobinuria because the person is having red color urine. The first sample is red. That is the meaning of paroxysmal nocturnal hemoglobinuria. I hope you got it. So let me show you the same thing in the theory. So what is the pathogenesis? So I told you there are two proteins, the guards are present. Two guards are provided by the guard on the surface of the blood cell. CD55, CD59. CD55 is known as DAF, decay accelerating factor, DAF. And CD59 is known as MIRL, that is membrane inhibitor of reactive lysis. Membrane inhibitor reactive lysis. Both of them are synthesized from GPI. Can you see the cell membrane? This is the cell membrane. It can be RBC, it can be WBC, or it can be platelet. On the surface, can you see the two guards? This is CD55, this is CD59. Appreciate the two guards. So whenever, now see the two diagrams. Can you see the two diagrams? The upper half, the lower half. See the upper half. The upper half is a normal person. Can you see the RBC? The RBC is shown to you. On the surface of the RBC, the two guards are present. See, CD55 is present, CD59 is present because their precursor GPI is present. Now, during night, when the complement get activated during acidosis, the complement is trying to do the lysis. See, C5 to C9, C3, everyone is coming on the RBC and trying to rupture it, but the guards are present. Thankfully, the guards are present. Guards are preventing the RBC from hemolysis. So there is no hemolysis at the end. That's why in the morning we don't have pancytopenia. Like the normal person don't have pancytopenia. But imagine the unfortunate persons, some patients are unfortunate, they don't have these guards because the gene required for the synthesis for the precursor GPI is mutated. So there is mutation in the GPI, there is no GPI, no CD55, no CD59. So during night when they sleep, everyone sleeps. Now there is no person who don't sleep for all. So whenever they sleep, at that time the complement become activated because of acidosis. So the complement is coming and trying to destroy the RBC. But there are no guards now, so RBC get ruptured. And it is leading to intravascular hemolysis. Whenever the RBC get ruptured, the hemoglobin will be leaked. This hemoglobin will go in urine, leading to hemoglobinuria. So it's nocturnal during the night hemoglobinuria. It's paroxysmal nocturnal hemoglobinuria. The same thing is written in the form of the flowchart. You can appreciate, right? So all the precursors like RBC, WBC, platelet, all of them, they have a gene, PIG or GPI, one and the same thing. So either you say phosphatidyl inositol glycan or you say glycosyl phosphatidyl inositol. One and the same thing, this gene is mutated. So they don't have CD55, they don't have CD59, right? So whenever the blood become acidic, the complement become activated and complement do the lysis. It's intravascular hemolysis, not extravascular. What are the clinical features? I told you there is hemolysis. The two properties of the hemolysis, it's not continuous. It's an attacks. Every night it occurs, or you can say whenever the person is sleeping, at that time hemolysis is there. Whenever the person is awakened, at that time hemolysis is not there. And usually it's nocturnal in the night because during sleep the pH of the blood become reduced and become acidic. And it leads to the activation of the complement. I explained you. There is pancytopenia because not only RBC, WBC, platelet, everything is destroyed because the guards are absent in all of them. So basically patient have anemia because of destruction of RBC, leukopenia because of destruction of WBC, and thrombocytopenia because of destruction of the platelet. So patient have lethargy, fatigue because of anemia, increased infection because of leukopenia, and increased bleeding because of thrombocytopenia, right? Apart from that, CD59 have one more function on the platelet. Because of the absence of CD59, there is thrombus formation. So thrombosis is the third thing. So this is a typical triad of PNH. Please learn that. So typical triad of PNH have three things. Patient have hemolysis, which is intravascular. Patient have pancytopenia, less RBC, less WBC, less platelet. And patient typically have thrombosis. Learn the typical triad of PNH. In PNH, 3 things happen to the patient. Can you tell me what are the 3 things happen to the patient in PNH? Number 1, say intravascular hemolysis, which is paroxysmal in nature. Number 2, say pancytopenia. The RBC, WBC, platelet, all of them are formed. Because of hemolysis, only RBC fall. But pancytopenia, everything is falling. All 3 lineage. And the third thing, patient have thrombosis because CD59 have an additional function on the platelet to prevent thrombosis. When CD59 is absent, now there is thrombosis also. So this is the typical triad. Now coming on the lab finding, I told you all the things because of intravascular hemolysis that will be seen here. So patient have hemoglobinemia, hemoglobinuria, methemoglobinemia, hemosiderimia. Everything is released in the blood and go in the urine, right? The patient have mild jaundice, the patient have mild anemia, the patient have reticulocytosis. Now there is one screening test, one confirmatory test. The screening test is heme test. What is heme test? It's very easy. So take the RBC in test tube and acidify them. Artificially. We are not asking the patient to sleep and natural acidification of the blood. We are acidifying the serum artificially. You add the acid from outside. So whenever you add the acid, if the guards, can you see the guards? On this RBC, the 2 guards are present, but on this RBC, the RBC guards are absent. So this RBC ruptured, but this RBC is intact. So you take the serum, you acidify the serum, you will see the RBC, some of the RBC will rupture, right? If the patient is having PNH. So that test is known as heme test. You acidify the serum artificially and you see the rupture for the RBC. If it is a normal person, all the RBC have the 2 guards, so none of the RBC will rupture. But in PNH, some RBC will rupture, some will not rupture. So that is the screening test. The confirmatory test is flow cytometry. So what is flow cytometry? Flow cytometer is an instrument in which you will flow the blood of the patient. You will take a test tube and flow the blood here. Now in this, in this flow cytometer, we can make a graph on the monitor of the screen, right? We can select what do you want on x-axis, what do you want on y-axis. In the graph, there are 4 lines, right? This is 0. So this is positive, this is negative. This is positive, this is negative. So there are 4 quadrants. In mathematics, we know. So this is the quadrant in which both the things are positive. This is the quadrant in which both the things are negative, right? This is the quadrant in which one is positive on the x-axis, on y-axis it's negative. This is the quadrant, this is positive on y-axis but negative on x-axis. You can understand. So the same graph we can obtain on the flow cytometer, right? So can you see the graph? Let me explain. Can you see this? This is the graph, this is 0 here. And can you see this is the graph? This is 0 here, right? You can see the 4 quadrants, right? Now, if it is a normal person, you select x-axis and y-axis as CD55, CD59. On any axis, you can select any of them, the 2 guards CD55, CD59, and run the RBCs in that. In the flow cytometer, run the RBCs, run the blood. So in normal person, all the RBC have both the things. So this is also positive, this is also positive, so it is coming in this quadrant. Both the things are positive. Right? And here, in PNH patient, you will get bimodal distribution of RBC. Some RBC is both things positive, some RBC is both the things negative. So it is a typical graph of normal person. This is a typical graph of PNH patient having bimodal distribution of RBC. I mean to say this is the graph, this is 0. This is positive, okay. This is negative. So I don't know what I have said you previously, but this is the quadrant in which both things are positive. And this is the quadrant in which both things are negative, right? This is normal. So you can see here this quadrant and this quadrant, right? So both things are positive, both things are negative. So you are getting bimodal distribution, some RBCs in which both the guards are present, some RBCs in which both are absent. But normal person, all the RBC have both the things are present. None of the RBC is falling anywhere else. So that is you can get that is flow cytometry. This is confirmatory test. So what we have learned? We have learned PNH, Paroxysmal Nocturnal Hemoglobinuria. So I told you the pathogenesis. The pathogenesis is the mutation of GPI. No GPI, no CD55, no CD59. And that is causing the lysis of the blood cell leading to pancytopenia. I typically told you the triad. I told you one screening test and one confirmatory test. Okay, the name of the screening test is heme test. And name of confirmatory test is flow cytometry. You can explain, you can draw, and that is the only thing you have to learn in PNH. Let me tell you some MCQs based on that. The first question, PNH associated with somatic mutation of what? Does it associated with mutation of DAF, decay accelerating factor, or it is associated with mutation of MIRL? that is membrane inhibitor of reactive lysis. So what does it associated? Which mutation? Or it is GPI, that is glycosyl phosphoridol inositol. Or is it C8 binding protein? So what is the exact mutation which takes place in PNH? Can you please try? The question is tricky, so please beware. I guess you all are right. The correct answer here is C. It's GPI. The mutation is in GPI which leads to absence of these two. So this is CD55 DAF and this is CD59 MIRL. So both of them are reduced or absent because of mutation in GPI. So mutation is in GPI, so don't get confused. The next question, heme test is done for. Is it PNH? That is paroxysmal nocturnal hemoglobinuria, or megaloblastic anemia, or sickle cell anemia, or thalassemia. Can you please try? The question is very easy. I hope you all are right. The correct answer is PNH. So heme test is the screening test for PNH. The confirmatory test is flow cytometry, right? In heme test, we artificially acidify the serum and look for the hemolysis of RBC. The next question, PNH is due to defect in. Due to defect in CD59, CD15, CD100 or CD20. Again, a very easy question. I guess you can try. I hope the question is very easy and you all are correct. CD55 and CD59. The two things are defective in PNH. Both of them are absent. CD55 and CD59. Okay, out of them, CD59 is given in the option. CD55 is DAF, decay accelerating factor, and CD59 is MIRL, membrane inhibitor of reactive lysis. Both of them are defective, but one is given in the option. We will go with CD59. That's all about it. Hello everyone. I hope you understood this topic with crystal clear concepts. Now, if you want the notes of this topic and all my YouTube session notes, then you can click on the link which is pinned in the comment box. Thank you so much for your kind attention, for your patience, for your valuable time. Now here a QR code is provided to you. You can scan it if you wish, and via scanning it, you can connect with me on various social media platforms like Instagram, Telegram, WhatsApp, where I share educational content which will be very useful for you. So if you wish, you can take the snapshot or you can scan it directly. And here is the contact number provided to you. You can save this contact number. It's 9833032948. This is for WhatsApp support, chat support. It is not for calling. So if you have any doubt in the topic which I'm teaching you in this session, and if you have any doubt in other topics also in pathology, pharmacology, microbiology, PSM, medicine, you can text your query here. And if you have any topic in your mind and you want me to take that topic, to schedule that topic in YouTube, so you can also text that topic here. So if many students are demanding the same topic, we will schedule it soon. So thank you so much. Wishing you all the best. Bye-bye.